we are really thrilled to have you all here. I think, this is our dissemination event of what we have been really working on for the last 2024, 2025, and early 2026, I would say, especially with the Resilience Collaborative that's supported by Johnson & Johnson Foundation. I think it had been a period of struggles, and it has been a period of a lot of learning, but I think it had been absolutely a period of such a joy of all the results that we have been able to achieve through this period. I think we are absolutely thrilled to share the work that we have been doing during this period. And we have all our partners, distal and proximal, all of them here. And we really look forward to showcase what we have been able to achieve during this small period, and how we are going to continue on with this work is also something that we want to present. Over to you, Shilpa, to take us through the initial sections.
Thanks, Vardu. A warm welcome to everyone, and so happy to see all of you and many familiar faces and new faces. Welcome to this call. So I will take about 3 to 4 minutes just to give a quick outline of the presentation today, and then also a little bit of background who are new to this meeting. So next slide, Nikita. So we all know that 2030 is not very far, and we do have a shortage of 11 million healthcare workers, primarily in lower and middle income countries. Rising stress and burnout, which all impair healthcare workers' well-being, and focusing on their mental health and well-being is so critical. Adding to this complexity is the angle of polycrisis, systemic issues, and also the missing perspectives. When I say missing perspectives, we can think about gender equity, participation, anticipation, but I think what we really miss is the healthcare worker perspectives, and I'm glad that some of the work what we have done over the last few months, which also gets those perspectives into this work, and Nikita would be presenting about that. Next slide, please. Yeah, just to give a quick background as to what the Resilience Collaborative is. The Resilience Collaborative is a global community of practice started way back in 2021 by the Center for Healthcare Worker Innovation at the Johnson & Johnson Foundation. And we have Sarah, who's joining on the call, who's been very important in getting this going. Initially funded by the Johnson & Johnson Foundation from 2023 to 2025. And the overall aim is to promote healthcare worker resilience and supporting their well-being, preventing burnout. The George Institute has been the secretariat or the host of this global COP since 2023, and we continue to do so. Next slide. And Reconnections is the 2024-2025. I've been part of TRC 2023, so it's a little hard for me to actually look at the timeline and say when we started. But Reconnections is where we had our partners, Reach Digital, Dimagi, and us, TGI, coming together to progress the Resilience Collaborative work. So the overall goal of this reconnection was to advance equitable quality of care, prioritizing the mental health and well-being and resilience of healthcare workers and systems they support through leadership development and capacity building. And again, also strategically disseminate learnings to empower healthcare workers and influence policy. Can we go to the next slide, Nikita? Yeah, this is the theory of change, what we developed. So the goal is in the center. What I just mentioned has 3 components. One is the COP itself, then there is the system, and there is the knowledge synthesis and management. So in today's presentation, we will be covering all of this outcomes and the different activities what we have gone through over the 2024-2025 phase, and of course the outputs, the outcomes, and also what went well, what did not go well, what were the hiccups, what were the challenges. But it has been a journey by itself, and we are going to talk about it in much more detail by me and of course all the partners. Next slide, please. Yeah, and these are some of the assets which we'll be focusing on today, looking at the TRC assets, the toolkits, the digital solutions, and also the evidence synthesis and the research work which we carried on done the last year. So that was very quick because I didn't want to go into the details. But with that, I will hand over to Sianai from Reach Digital Health to present the work from what they have done through the Resilience Collaborative in the last 1.5 years. Over to you, Sianai.
Thank you so much, Shobha. Yeah, next slide. Yeah, so I think, rich sort of supported reconnection and thinking around deploying, supporting re-engagement among health workers through sort of deploying new content, which we call Talk to Connect on the WHO Health Alert platform. And so the aim really was to try and test whether, these WhatsApp-based digital content can help, healthcare workers improve resilience and communication. And so we utilize this platform because it has a wider reach, it's a global sort of reach. Next slide. So in terms of what we deployed on this, the core module of the new content was called Talk to Connect, and this module is sort of a communication module that was designed to sort of help health workers to improve their communication. And so within it, it is sort of the learning content, but also the assessments. So a healthcare worker does sort of a pre-assessment to check like their baseline sort of level of communication. And then they go through the module. Then after 30 days, they then do a post-assessment. And then within this new content, we also included questions around healthcare worker occupation to try and think about segmentation as the types of healthcare workers that we are engaging. We also included some assessments on quality of care to just understand the quality of care from a healthcare worker perspective. Next slide. In terms of sort of scale and engagement, on the WHO Health Alert platform, we had about 37,301 healthcare workers registered on the platform. So that means this is the group that was exposed to this new content. And about 7,000 of them registered post, I think, the launch of the wellbeing knowledge modules on that platform. But in terms of the actual engagement from this 37,000, we had about 6% who engaged with the new content, either the Talk to Connect module and its assessments, or the quality of care survey, or the other segmentation components. Next slide. So in terms of the insights, I think the main insights come from this Talk to Connect module, which was our main sort of content. And we see that although like engagement was modest, I think we had about 457 who started engagement with Talk to Connect in its various forms. And these 457 were like mostly young, urban-based healthcare workers in sub-Saharan Africa. But what we see from sort of their baseline assessments is that they showed a huge gap in terms of communication skills, with about 64% scoring below the perfect assessment score. And these assessments were like 4 questions that had like answers that they had to pick whether they are correct or not. So we see that there was a gap there. But the other component that we saw is that retention on engagement with this new content was poor. And then on the quality of care assessment, what we also noticed is that there were various questions that we asked, but one thing that came up is that we noticed that there was high presenteeism. It's a word that I just sort of created, but to some extent. But what I noticed is that healthcare workers reported that they usually work most of the time, even if they are not well, which is, I think, a big issue. But across all the insights that we saw, we noticed that community healthcare workers and social workers had sort of larger baseline gaps. Next slide. In terms of impact, I think the greatest impact story came from Talk to Connect, which was our core module. I think what we noticed is that post assessment, we noticed that there was an improvement in the assessment scores. So that was great because that score doubled to like 71% from 35%. And also there was an improvement in terms of the ability to ask open-ended questions, because one of the assessment questions was around open-ended questions. So we saw an improvement on that. And then we also got reflections from about 141 of the healthcare workers that participated in this or that engaged with Talk to Connect. So we asked them to give us feedback and what they thought and reflect on what they thought about Talk to Connect, and they gave us really good feedback. Thank you. Next slide. In terms of key learnings, I think I've emphasized that Talk to Connect seemed like provided us with the clearest of the impact, showing that this type of training can yield meaningful improvements. But what we saw, I think one big thing is that engagement on this self-guided digital intervention is challenging. And next slide. The biggest challenge, as I said, is engagement. I think engagement was a challenge, although we had a modest group sort of engaging with this new content. Completing post-assessments, we saw that reduced to like 14%. So I guess the biggest lesson is that although they have access to phones, they have access to internet, that does not imply that they'll be engaging with this new content. Next slide. So going forward, what we were thinking is that one, we could sort of improve the sort of the service itself, the design of the service through automated drop-off recoveries within the journeys that the healthcare workers go through this service. We could also think about other voice options, in the learning module, and expand to more languages. But I think the biggest point was around thinking around, engaging with the Ministry of Health departments as well as other facilities where these health workers work to try and sort of incorporate these modules into the continuous professional development recognition so that we encourage healthcare workers to complete these modules. Thank you.
And thanks everyone for joining in. It's great to have all of you. I'm here to share about the Monday's reflection on this engagement and just reviewing the 1.5 years that we were part of this project. So last year or early this year, when we sort of tied the ribbon around it, it felt great to just see through what we were able to collectively build, learn, and also where we headed. And I think it's genuinely interesting to see the focus that it has had on resilience and mental health, especially for those who are caregivers and frontline workers. Nisha will co-present with me. Can you move to the next slide? Yeah. So to set the context, so this engagement has had 4 interconnected work streams that have been running in parallel throughout our engagement. At the center of it was the WebMe, which was the user pilot that we ran in Uttar Pradesh, and it covered about 1,000 plus frontline workers across the Ministry of Health frontline workers, and we onboarded finally about 1,018 frontline workers. And the idea was to essentially deploy the WellMe application, and we'll talk about that in a bit. And have the frontline workers focus on their own well-being alongside the work that they were doing. The second sort of pillar was the FLW advisory panel. This was a globally representative group of about 10 frontline workers across 5 different countries who joined us on a panel to co-create the WellMe tool. And typically we've seen solutions and applications being deployed where the users are frontline workers, but this time the effort was to have the frontline workers be a part of the panel, and for them to kind of show a more strategic and consulting sort of role in shaping the WellMe solution. We also piloted a WhatsApp peer community across 3 different circles, which included about 53 participants. This was to test whether the peer connection and the support system could independently strengthen resilience, which was different from the WellMe application engagement. And underpinning all of this was our TRC collaboration with TGI and J&J. And it also included aspects on research, the toolkit validation, etc. So I just wanted to kind of share this framing with you as we move to dive deep into each of these aspects. But essentially what we really saw over the last few months was that the frontline workers really moved from silent endurance to really collectively reflecting on the need for an application that focuses on their well-being and really empowering themselves before they can reach out to the community and offer services. And the next few slides, we will really bring this to life for you. I'll hand this over to Nisha to walk us through the specific pillars of the work.
Yeah, thank you so much, Divya, for setting that context. Hello, everyone. Thanks for joining the call. And I'll be walking you through the three other pillars that Divya mentioned about was a part of the project. Firstly, let's start with the FLW advisory panel. So one of the most important decisions we made early in this project was to ensure that frontline workers were not just users of WellMe, but contributors to its design. We wanted to create a space where frontline workers could openly reflect on stress, self-care, and what actually feels practical and usable in their day-to-day realities. And so to do this, we created a frontline worker advisory panel, selecting 10 panelists from 61 nominations. Yes, it was a difficult job. Received across 5 countries. And over the course, we had 8 structured sessions, which also included multiple one-on-one interactions, where we engaged directly with frontline workers to better understand what truly resonated with them, what their thoughts are, how do they perceive stress or resilience, and what are the adoption parameters or barriers that we could learn from. One of the strongest messages that emerged was the importance of co-creation over consultation. Panelists directly influenced content design, learning approaches, and accessibility features within WellMe. And their feedback shaped practical decisions around, for example, local language audio, short form stress management videos, journaling prompts, and daily micro practices. We also observed a meaningful shift in how participants spoke about stress and self-care. So we began the structured sessions right from the introducing the concept of stress and resilience. And by the end of the engagement, many panelists described feeling more confident in coping with stress and more intentional about applying resilience practices in both their personal and professional lives. Another important lesson or learning was that structured engagement formats work far better than open-ended discussions alone. This was kind of expected because we know frontline workers have a huge workload, and expecting them to, come up with thoughts themselves, think through things clearly would have been overwhelming. And so we had guided reflections, we had check-ins and resilience exercises that created a deeper participation and also resulted in richer insights that we received from them. At the same time, the process also highlighted some operational realities such as time zone coordination, because we had frontline workers from across the globe from different time zones. So coordination was a bit of a challenge, and also uneven regional participation. Somehow we were not able to get representation from Brazil, which was one of the aspiring regions we wanted to tap into. These are important considerations as we think about building future-led communities at scale, and so we wanted to be upfront about it. Now we'll move to, next slide please, to the WellMe 1000 user pilot. As Divya mentioned, this segment focused on implementation, that is testing whether the WellMe platform could translate into sustained engagement in real world frontline settings. The pilot was implemented across 4 blocks in Gorakhpur district, where we successfully onboarded 1,018 frontline workers. This exceeded the original target of 1,000 users we had set. What was especially encouraging was not just the scale of onboarding, but the depth of engagement we began to see over time. One of the strongest indicators of adoption was the login success rate. Nearly 88% of trained frontline workers successfully accessed the platform, which is particularly significant in a public health context, right, where digital adoption can often be challenging. Further, engagement data showed that users were not only accessing the platform, but actively engaging with resilience building content. So nearly, just to give you some examples, nearly 20% of the users completed the full Learn journey. There is a module in the WellMe tool, it's called Learn. It introduces the users to different concepts about stress and mental well-being. So we had 20% of the users complete that, and 395 users collectively contributed more than 23,000 journal entries. This demonstrated strong reflective engagement and sustained participation. Now, from an impact perspective, we observed positive movement in both resilience and well-being indicators. The peer support cohort demonstrated the strongest gains. I'll talk a bit about this in detail. I'll talk a bit about this in the next slide. But particularly in well-being outcomes, reinforcing the value of combining digital tools with social and peer-based reinforcement. At the same time, the pilots have faced several implementation realities that are important to acknowledge, honestly. And so device access challenges, digital literacy barriers, and timing constraints related to ASHA strike periods and festival seasons all influenced participation and required adaptive field support. However, several factors contributed significantly to the success of the pilot. Smaller cohort-based onboarding sessions improved engagement quality. As they were mentioning, we had several batches for onboarding, more than 47, and we ensured that each batch did not have more than 30 frontline workers. And so this really helped in improving the engagement quality. ASHA Sanginis also played a critical role in peer troubleshooting and encouragement, and strong institutional support from district and block officials, the local bodies. They helped establish trust and legitimacy from the very outset. I'll talk about the third segment now. Next slide, please. The WhatsApp peer community. In addition to the core WebMe platform, we also experimented with small peer support WhatsApp communities to understand whether social reinforcement could strengthen resilience outcomes. So we created 3 WhatsApp groups, 3 WhatsApp circles, and about 55 participants, including across the groups, engaged in peer-based conversations. They were also a part of the pilot, and just from the pilot cohort, we picked up 55 participants to participate in the peer community. On these circles or groups on WhatsApp, we shared reflections. The participants also had a chance to consume multimedia resilient content. And collectively, we observed that these groups generated more than 500 video views and demonstrated the strongest well-being improvements across all cohorts. As I was mentioning on the previous slide, the well-being impact was higher in the peer cohort group that we had. So talking about what worked well was the use of short multimedia content instead of longer text-heavy discussions. The participants also responded positively to some, random short videos on mental health and resilience. We also sent some festival-linked prompts, because it was the last quarter of the last year, which is very festival-heavy time in India. So our prompts or messages on the group was also related to such occurrences or festivals that people were experiencing in their lives. And then practical stress management exercises were also shared that felt relevant to their everyday lives. We also observed that engagement patterns were closely tied to work routines. Most of the interactions that happened on these WhatsApp groups happened during weekdays and within the working hours of the frontline workers. So this suggested that the community became integrated into participants' professional rhythm rather than existing separately from it. Earlier, we were hoping that there would be more interactions after the working hours, let's say in the evenings or early morning, when frontline workers are not really involved with their service delivery work. But that was not how it went. So it's good to see that the community that we created became a part of their professional cycle. Another important insight was the role of peer champions. In every group, we had 2 to 3 highly active members who helped sustain momentum and encouraged quieter participants to engage more actively. And so we did not also leave any opportunity in highlighting these champions. There was a lot of buzz created around, these champions every month, so as to also encourage the other more dormant users to open up and perhaps, grab the spotlight during the next time. So that also kind of helped, and we saw over time there were more engagement. And the peer community also helped validate an important hypothesis, which we had in mind before we started this, was to see whether peer community itself can strengthen resilience, even beyond a direct app or a tool engagement. Participants in the peer cohort showed, as mentioned earlier, I'm just reiterating, showed the highest positive shifts in well-being and the fewest negative resilience changes across all cohorts. Okay, all good things said, but also at the same time, we identified areas that require strengthening going forward. While engagement remained largely facilitator-driven, more organic peer-to-peer dialogue will be important if these communities are to become fully self-sustaining over time. And that is something that was good enough, but in future, if we are to deploy something like this again, we'll have to also think about other things to get more peer-to-peer dialogue or conversations happening on groups. Lastly, on the next slide, I will move to impact, learning, and future directions. As we reflected on the pilot as a whole, the findings went beyond app usage metrics or survey scores. A few cross-cutting themes consistently emerged across implementation. First, digital tools alone are not enough. Human support systems, including facilitators, Asha Sanginis, and peer champions, played a significant role in building trust, encouraging engagement, and sustaining participation over time. Second, the pilot showed that awareness itself can be transformative. Many frontline workers had never even previously viewed self-care or stress management as something legitimate or necessary for themselves. But over time, we observed a gradual shift from passive endurance towards active self-management. We also learned that practical low-effort habits such as hydration reminders, mini breaks, journaling, and mindful exercises were much easier to sustain than longer or theory-heavy intervention. Perhaps most importantly, peer connection amplified impact. These learnings now directly are shaping how we think about the next version of WellMe and future scale pathways. Looking ahead, the next phase focuses on 3 priorities. First is dissemination and advocacy. We shall be using these findings to strengthen conversations with district and stakeholders around frontline worker well-being. Second, based on the user feedback, future generations of WellMe will further strengthen accessibility, onboarding simplicity, audio and local language support, and peer community functionality. And third, exploring pathways for scale and sustainability with the long-term vision of reaching significantly larger frontline populations through adaptable and evidence-based digital resilience support systems. I'll close with a quote from one of the participants that captures the spirit of this initiative. This is a user from Uttar Pradesh pilot. She mentions that the WellMe journey was good for me and the entire experience was awesome. For us, this reflects something deeply important, which is that frontline workers are not only in need of support, they deeply value being acknowledged as people, seen, heard, and cared for beyond their roles as service providers. And so the strongest takeaway from this pilot is that frontline workers are not resistant to well-being support. In fact, when support is accessible, practical, culturally relevant, and designed around the realities of their lives, they actively engage with it and embrace it.
So I will start off with the work what we did, led as part of TRC from the George Institute. I will start and then hand over to my colleagues who will present each part of the work as we go on. Next slide, Nikita. So I'll be briefly talking about the community of practice and also the toolkit update, what we did as part of the reconnection. So when we started this, the Resilience Collaborative, I think we started with the 0 number way back in October 2023 because of various challenges of the GDPR, and then we couldn't have the member migrate from the earlier system to the George Institute. So we started from scratch, and then we are happy that throughout the work what we have done, we have about 600 plus individual members, and some of them also represent organizations, and nearly 38% of them are healthcare workers themselves, and many of them are from lower and middle income countries. So it's not only healthcare workers, we also have former healthcare workers such as myself, researchers, academicians, middle management, professional organization leaders, and of course resilience practitioners and others. So one of the challenges, and also a good challenge to have, is the engagement bit. I think we have our own challenges and also learnings from the engagement part. So, but we continue to do frequent meet and greet, the newsletters which you get every month, the webinars and the social media updates, and the LinkedIn community which has been active over the last 9 to 10 months. And many of the members have actively been involved in the research and evidence synthesis work, and happy to see that some of them also joined this call and also been involved in the toolkit validation as well. And one of the other main initiative we took up was the My TRC Leadership Program cohort itself, which Ashish will talk about in a bit. Next slide. Yeah, these are some glimpses from the newsletter and the resource hub and the social media post. Next slide. And the toolkit, which was one of the core component of the work what we did, in the last 1 year. So to give a little bit of a context to this, so there was a toolkit which was developed by the Center for Healthcare Worker Innovation in 2021, which was specifically for program managers to build healthcare worker resilience. In 2024, we actually had a consultative workshop across different mental health professionals, and one of the key inputs which we received was to have healthcare worker represented in this work. So we actually went and met many healthcare workers across different regions and online, and actually developed this toolkit and a facilitation guide, which helps healthcare workers themselves to start conversations around mental health, and also develop simple intervention which can strengthen their well-being at an individual level, and also at the organization level where they work. But it could also be like an advocacy tool which they can bring out to the larger system, where they can say that these are our issues, these are our stressors. So this was the work which we did, and pretty exciting as well. Next slide, Nikita. And these are some of the pictures. So this was developed in 2025, and it can be implemented by healthcare workers themselves. And we have conducted validation exercise in India in multiple locations, Maldives and Zambia, and of course tested in different contexts and across diverse cadres, process and content validated. We want to continue this work. So the evidence synthesis work which we have, which builds on the actual intervention which works for healthcare worker resilience. So that will be, once it's published, will be added to this toolkit. So anyone who wants to use the toolkit has as a guide which can start off mental health conversations, but also has the evidence to support it. So one of the outcome which we really want to highlight, and we're happy to have Henry from Zambia, who's joined the call, that they also took up this work and has submitted a proposal to continue this work across in Zambia. Next slide, Nikita. Yeah, these are some of the pictures from Maldives and Zambia. Next slide. And again, the representation of healthcare workers in these workshops. And one of the quotes I would like to mention here is that, one of the health workers suggested that, this toolkit should be, designed in a way that we could use it for ourselves. So if we can't, then at least we can tell our supervisors, okay, look out, this is a toolkit and this is what helps us and this is the evidence. So we take that learning forward, and happy that, they could open up and then share their experiences with that. So with that, I will stop here and hand over to Sushri. Over to you, Sushri.
Yeah, thank you, Shilpa. And thank you everyone for staying with us so far and listening so patiently. And just building on what Nisha presented on the WellMe application scale-up, for that, we have carried out this implementation research on evaluating the feasibility of deploying a digital solution, which is the WellMe, a mobile-based application for improving the resilience in frontline health workers, such as ASHAs and ANMs, in the state of Uttar Pradesh in India. And the total participants in this study were 161, and the application was delivered in their local language, which is Hindi, with different modules such as learning modules with different concepts of mental health, as well as empowering them with the self-assessment of their mental health, and practice module with some sort of behavior change practices for them to learn and implement in their daily lives. And these are the key findings I want to highlight, that we observed a significant improvement in their coping ability and a modest increase in their resilience. However, this psychological distress level remained largely unchanged. And we think that because during the qualitative interview, the participants reported that time there was ASHA agitation in the region, which might have confounded this. And also in our adjusted analysis, we found that the participants with more than 25 years of experience showed greater improvements in their resilience, and the participants within the age group of 53 to 58, they exhibited very less benefit out of it, which is very clear, because age also has a influence on the uptake of the application and usage. And then the qualitative insights that also added a depth to these quantitative findings, where the participants expressed that there was a progressive shift in their engagement. It means they said there was initial resistance, feeling that it's yet another digital application in our daily routine and tasks, to the recognition that this application is something that is meant for their own self-care and for themselves. That was that progressive shift from the initial phase of the implementation to the end line. And there was tangible benefits and behavior change that they shared and described about whether practicing deep breathing exercises in their daily lives or taking some rest and break in the daily routine of tasks and job, and also very consciously managing their emotions, that they started doing it after using the application. And they also expressed that they learned new concepts of mental health that they were not much aware or were not able to recognize before, but now they learned it. And they are not limited to that. They also shared those learnings with their other peers who were not part of this study, as well as the family members, and which shows that knowledge transfer, that it didn't just stop there within those 161 participants. It also spread all over, and there's been a spillover effect of this intervention. And few key features that led to better accessibility and acceptability of this application were definitely the local language, which is Hindi, the content were in their local language, and the audio visual format. There were texts where they found the audio attached alongside the texts or the questions or the answers, which was easier for them to access the content, given the varying age group and literacy. And then definitely the flexibility and self-paced nature of that application, which helped them engage at their own pace and free times. And apart from that, however, there will be benefits as well as some challenges. For example, at the individual level, they expressed that there was time constraint because of the heavy workload. Also competing work priorities at work as well as at home, and using various digital applications for reporting or for their work purpose. There was a fatigue of digital application. Few have expressed regarding this, and the variability in digital literacy, as well as the context, which is rural and urban context, which also led to the limited use of the application for some participants in the study. And at the structural and technical level, few expressed about depending on their family members to complete their digital task, as many older participants, they usually depend on their tasks for daily routine tasks, which involve digital applications. And there were few device related issues that they perceived and expressed. For example, it was the data insufficiency during the installation of application, or the perceived connectivity issues, or maybe the syncing issues that they faced, or the updation of the application, or breaking down of their phone, or the hardware problems, or mobile hanging or crashing. So all these things they expressed, which were their device related issues. And in some mobile phones, we faced that issue of restriction because of the health department provided mobile phones, but apparently we were able to manage that challenge during the implementation phase itself. And from the implementation standpoint, as our implementers also expressed, the compressed timeline of completing the trainings because of the delay in the approvals, or the field issues or the context. And then there was a bit lack of contextualization, which was from the participants' side. They felt that the language or the people or the way the training was conducted, because it's usual that their familiarity with the type of training, it's been about their work, but it was something that was definitely for them, for their mental health and their self-care. So definitely it was not very familiar. They were not very familiar with these kind of trainings. And there was also the challenge of building the narrative about the exclusivity of this application for them. Initially, this was a new concept for them, and it was also difficult to convey them that this is for you, not any task or target to complete. And a few app design and features that they wanted to be incorporated in the application. For example, some shared that Instagram reels or Facebook videos that we see, or YouTube reels, which are of 1 or 2 minutes, it's quick, and we immediately derive our happiness from that. So if something like that, so this is kind of accommodating to diverse features and participants' choices. So this is the challenge that we feel, and they recommended to integrate in the application. And here are some participants' responses, which kind of reflected the relevance and definitely the benefit of the application that they felt, as well as many of them, a majority of them also advised for the scale up of this application and sharing it with wider population in their workforce. So yeah, but at the end, I would like to highlight that these kind of mental health digital interventions cannot work in isolation, and we need technical adaptations as well as system level support for equitable access for all the cadres of this health workforce. With that note, I think I can share some glimpses also, if Nikita can. Yeah, these are few glimpses of the inline surveys and implementation and training, as well as the group interviews in the qualitative part. So with that note, I think I'll hand over it to Ashish to carry it forward. Thank you, everyone.
Thank you, Sushri. Good day, everyone. I will now briefly speak about a few connected themes of work. One is the evidence synthesis work stream and the My TRC leadership program. So you see, broadly, the evidence synthesis work stream helped us to consolidate what is known on the one hand, but also what remains underexplored in the health worker resilience and burnout space. Our colleague, Dr. Prachi Pandir, was part of leading this effort. And I mean, it's so good to see so many of you on the call who are already involved in these efforts. So yeah, it's good to see you all as contributors and participants. So on the right side, you'll see on the box the research outputs. There are published outputs and some under review. A couple of them are narrative reviews, one on the defining resilience, which we thought was essential in really beginning and putting labels and clarity there. There were things about focusing on the compassion fatigue among frontline healthcare workers. But I'm going to focus on two systematic maps. The first was the systematic map on the interventions for improving resilience among health workers. We mapped over 580 studies. And what we found was that the most common interventions focused on the resilience training, the workplace training, and mentorship. But it also highlighted clear evidence gaps, which were oriented around systems and policy level outcomes, patient safety, performance, presenteeism, and other things, which really tells us that there is a growing interest in resilience interventions, but the evidence base remains very focused on individual and psychological outcomes and not enough on systems level change. The second systematic map is related to the burnout factors, and that is for healthcare workers in low and lower middle income countries. So we run studies, studies over 320 of them. And while most of the studies focused on doctors and nurses, we realized community health workers, associate professionals, and workers in conflict-affected settings were mostly underrepresented. So, like before, we noticed burnout factors are also frequently studied at the individual level, followed by organizational level, but the system level factors are much less frequently studied. And what that points is a real important gap, that burnout is not only about individual level stress, it also reflects workforce conditions, the organizational design, governance, health systems pressure, and so on. And therefore, the implication is fairly clear. Future research, as we are pressing and advocating for, and implementation as well, must generate actionable evidence that supports the workforce's sustainability, well-being, and service quality in low-resource settings. We can go to the next slide, where you can see some of these maps. If you can click, you can see that these are interactive maps where you can explore specific domains and look at variables, the interventions, and the sources themselves as well. You can filter them in many ways, but we will share these maps as both of these studies get published. going to go to the next slide. And this is the MyTRC leadership program, which was designed around the needs expressed by the community members, the frontline healthcare workers. The first MyTRC cohort ran from July 2025 to March 26. We started with 12 people, but faded to around people. But this 9-month journey combined mentorship, masterclasses, group learning, and very specifically an action learning program or a project which was utilized in organizations themselves. So program primary was built around practical leadership, governance, and systems thinking and initiative taking capabilities, while grounding the leadership development in real-world challenges faced by healthcare workers. And one of the main learnings of the MyTRC experience overall was that in resource-constrained settings, leadership is often forged at the front lines. We've seen practical examples of peer support or local innovations or even informal support that health workers find for themselves. And that really helps to reduce the amount of disruption or isolation or stigma that comes along with the challenge. And so this also indicates that healthcare workers are not only recipients of support when we think of resilience as a support, but they're also role models of resilience, care, and innovation. And that helps us flip the narrative and the way that we approach this work. So workers, health professionals are operating at a very delicate balance during crisis and distress, when systems and structures all become disoriented. And when there are no boundaries between personal well-being, professional roles, and systems responsibility, that's why health workers' well-being is essential for equitable quality of care across health systems. And following this experience with MyTRC, the graduating participants are going to transition into a core leadership group to contribute to TRC's strategy, theory of change, and help steward future cohorts as well. And this gives TRC really a repeatable, a scalable pathway for leadership development. So both these elements, the MyTRC leadership and the evidence synthesis work, directly connect to TRC's theory of change, which is about moving from evidence and community-based learning to leadership, implementation, and policy and systems influence. The frontline is where adversity is experienced, but it is also where innovation, care, and leadership are created. We'll go next to a story of change from Neelam, one of our MyTRC graduates. You'll see a brief video, and followed by that will be Vardarajan. Please come on, and you can share your reflections after that.
So many times it so happened that if even when I was a student, it so happened that if I'm sharing anything like my experience, so fear of judgment that came, but with the TRC that fear has gone absolutely. And interacting with other members of the cohort team allow me to reflect on my own challenges and learn from their experiences and realize that I'm not alone in this journey. They are also with me. So that support and that connection I can feel. During this MyTRC journey, one very simple sentence I learned, that is courage over comfort. Courage over comfort. I think that is the mantra of all the work, all the motivation that we are doing. And if I talk about as a nurse, when I was working as a nurse, I can share my experience with other fellow members, because during COVID, I was working in the COVID ICU. Basically, I was in the medical ICU, but because of the COVID cases, that the ICU I was working is turned into the COVID ICU. And that time, the burnout was not the case, that emotional trauma or the phase whatever we have seen. I think if I'll share that experience with my fellow nurses, it will help them a lot. And if I talk about as a faculty or as a teacher, currently I'm working in a college. So from the beginning of their nursing journey, if I'll share my experience as a clinical and whatever thing I'm learning from the MyTRC journey, I can share with them. So at least they will have an idea, okay, after that, this will be the scenario, and that scenario, these things can help. That I learned from MyTRC. So many times.
Yeah, I think that has been mostly the presentation of all the work that we have done and all the work that has happened that our partners have carried on. So now it's time to really sit down, and it was time for us to sit down and reflect, saying that what is that we take away from all this exercise. So I will be talking about few of them already both Dimagi and Reach have spoken about as well. So looking at the community membership and engagement. We did have a fancy number, that we think we could not achieve in terms of membership, but I think we ended up doing it. So that shows that there is a real interest in terms of people aligning with what the current needs of the health workers are, and we are able to generate that interest of this being a platform for them to be able to come together and be able to work on that. I think that was one of the major reflections that we have on community membership and engagement, right? You see that even for this particular event, not many have turned up, but have there been engagement? I would say certainly yes. I think the engagement has come from completely different forms that we did not necessarily anticipate, and that is why I think we evolved. Now we have a functional LinkedIn loop as well, where a lot of people exchange thoughts and also exchange engagement. I think that has been one of the wonderful thoughts and reflections that we have about engagement per se, and which clearly shows also that there needs to be multiple modalities for engaging with our teams. And one of the other bright examples of saying how the engagement has improved is most of our COP members have gone on to contribute in the systematic work or the evidence synthesis work that we have done in participating in systematic maps, and also have contributed in multiple ways in terms of being able to put up blogs and lots of other contributions as well, where all of them had aligned themselves with one particular way or one particular need that TRC had, and they came forward and they have contributed. So that has been a very satisfying reflection for us in terms of this particular aspect of membership and engagement. Leadership is ownership. I think this was completely a new experience for us. In fact, for all of us, except for Ashish, who has a lot of experience in this. So it was like, a very adventurous step that we were taking, but it really turned out well. I think the 7 of the 12 whom we had recruited for the first cohort completed the course, and not just completing. I think they really recognize the value of what this program could add into their lives. That I think was very, very satisfying, and we really hope to carry on this work forward, and we see how is that we can try to get that bit organized. Advisory panel, I think we had wonderful reflections from the Dimagi team. Can we move on? Nikita? Yeah, the evidence synthesis, again, with thanks Prachi for joining us. The Prachi has been leading this particular work, and these 2 systematic maps have generated so much of interest. It is just that, we were waiting for it to be published, and one of it is already published. And I think we will be soon, all of us will be able to access these maps freely. That this all of a sudden there was interest even from the commercial sectors, non-commercial sectors, and also the implementers. I think it addresses the very basic need of saying how and where should we intervene, and what is that we can do for our own people. That is very nicely addressed here. We really look forward to putting this up on our website and be able to make it available as a useful resource for all those who want to use it. The implementation research, I think that has been a fascinating example of completely different partners coming together. We had a field partner, we had technical partner in Dimagi, and us trying to do the research. It demonstrated the value of different people coming together, and that was a very deep reflection we had. Most of us would have written it off, saying that is it possible to do such a research in a community setting, in a public health system, and we made it possible. I think all credits to Dimagi and AIF. We don't have representatives from there, but they were part of it as well. And we, for our own self, I think we can take a pat on our own backs, saying that we were able to pull off such a research in such a difficult context in terms of public health workers and being able to talk to mental health about them. So I think that's a wonderful reflection, and it's more of it's more of gave us that assurance of saying that when things are done in the right way and with the right intent, it is possible for us to achieve what we otherwise think is very difficult. I think that's the greatest reflection we take from here. Can we move on to the next slide, please, Nikita? Yeah, health alert, like Senai had very nicely reflected on the key insights himself. So I'm going to skip this slide. Can we move on to the next? Again, Dimagi team had very nicely put in their reflections about both WhatsApp peer community and how it had contributed to the mental health of people as well. And yeah, so it doesn't stop here. Coming back to the engagement, right? One thing we realized was saying that our website was a little bit static, and it could have been a little bit more interactive. We have moved on to that phase where it has become more interactive, and probably we are collecting more stories as well. I think that is one of the major reflections and probably the learnings that we had as a team, saying that the impact that the stories create is something that is tangible these days, and it appeals to a much wider section of the society, along with other essential knowledge products like maybe publications or maybe tools per se. So I think that is something that we had learned. And again, the toolkit has been a fascinating example for us to be able to bring in completely different set of partners across the world, and right from the VOZ, the Vision Outreach Zambia, who are present here, and from Maldives, a private hospital being able to open up their doors for such a implementation. Not just implementation, I think taking up the ownership for this was really fascinating for us to see what can happen when the right tool reaches the right people. I think that was a key takeaway from this particular exercise of the toolkit that we had. Can we move on, Nikita?
My name is Aaron Chishas Nyangwe. I'm the business development.
Yeah, we have Mr. Aaron here, but we are playing the video. I think Nikita is struggling a bit to get the video on. Is it, Nikita?
Yes, just give me 1 second. Sorry.
Yeah. Yeah.
My name is Aaron Chishas Nyangwe. I'm the business development director for Vision Outreach Zambia. We recently held a validation exercise of a frontline health worker toolkit here in Zambia, working hand in hand with the University of Zambia. And we had to go through the process of engaging with the Ministry of Health to get their input and also their consent. Some of the key stressors that were actually identified included the issue at individual and the family. There is that term that is called the black tax, where family members tend to request for, at times, more than what this individual can provide. This is a great tool, and we are looking forward to implement it at different levels.
Yeah, I think most of the challenges have been already spoken about. I'm not going to stress too much of it. And also, I think I'm fully aware of the time constraints here. It's been a really satisfying journey for us. It's not just about the outcomes, the connections that we were able to make, and really being, so close to our entire title of Reconnections. We've opened up so many channels that continue to work on health workers' well-being. That has been one of the greatest outcomes of TRC so far. This is not a full stop here. I think we'll continue on this work. And now I hand over to Nikita. These are some excellent pictures that we have. We have been able to participate in global symposiums and also do a lot of other webinar series, and speaking with our community members regularly. We can see some of those glimpses, and now I would let Nikita take us through some of the actual voices from the field that we have captured. Over to you, Nikita.
Thanks, Vartu. I'm just going to quickly run us through a package of work that we undertook as a part of the TRC called the Voices from the Frontline. We started it off quite small and humble as just an initiative where we ask 1 or 2 questions to health workers, asking their experiences, asking them to share what really brings them back to work despite their challenges, so on and so forth. But since then, it's sort of grown and evolved over time to take on different media, different art forms, and even to co-creation and co-developing content with their input and with them as well. So just a quick glimpse of some of these for us today, and we just really look forward to expanding this work and for any contributions into this work that we just love to expand. So the context again being that, as Vartu mentioned, it was so crucial for us to allow and to even provide a platform for health workers to be able to share their stories in their own ways, in their own with their own voices, just to be able to tell their own stories, and for us to be able to provide that platform and try to amplify that using media, various popular media and art forms as well, just to spotlight their stories and their resilience, their challenges, and how they rise above some of these challenges, and how somehow that has happened so organically, but also to shed light on some of the more systemic and community things aspects that we sort of could help support and alleviate on different levels. So there are issues that have been discussed through these, for example, the lack of equity or the struggle with stigma or social aspects that sort of add to their burdens as healthcare workers. And so you would see some of these in in what we display over the next few slides. What you see on the right here is an collage that was submitted to be. It was actually selected to be displayed in the Art Hub at the Women Deliver conference that was held at Melbourne earlier last month. And this was to highlight. This was sort of to start a conversation on women healthcare workers and the inequity that they face with some of them with their wages, with their timings, so on and so forth. And that was a piece that was discussed through this collage. A couple of ways and different approaches that we have taken to the storytelling process is as I mentioned before, we had these interactions with especially, and we are grateful for that effort and for that opportunity that we had to meet with several healthcare workers in Gorakhpur in the beginning of the year. And a lot of conversations were had over what are their challenges, what do they see as their key concerns, what do they see or celebrate as their contributions, and what is it that supports them. So some of these were brought out through social media on various occasions. What you see on the left is a healthcare worker sharing her concern about their safety not necessarily being addressed or thought of all the time. And that was a social media post that we shared on World Day for Safety and Health last month. This video on the right, which I will play, was just a health worker sort of beaming with pride about how she could support a young lady in her village who was struggling with having a child, and how she was able to educate her, and how they were able to have a child, and how she could support them through that process, and just to see the sort of the real world impact that they're having in their communities. So just a quick glimpse at that before we move on.
और से तमाम तरह का बीमारी रहता है, वो सब बीमारियों के लिए हम लोग सब बताते हैं कि ऐसे करेंगे तो आपके लिए अच्छा होगा, ऐसे करेंगे तो अच्छा होगा, तो उसको स्वास्थ्य पिलाते हैं, दवा करवाते हैं सब। हमारी एक देवरानी है, उसके डिलीवरी बहुत दिन नहीं हो रहा था, तो उसके बारे में बताए, सलाह दिए, लगभग 12 साल में उसको डिलीवरी हुआ।
I'll just share one more video with us today. This is again a really powerful story that we heard from one healthcare worker, just the kind of social pressures, the stigma, and of a family just really struggling through her choice to be an ASHA worker, a community health worker in India, and how she sort of rose above those challenges and was, and just amazing to see her story of resilience and her strength. And even inspiring many others to rise like her in her village. So just quickly, the video is in Hindi, but you would see the transcript.
हमारे मतलब शुरू में जब हम आशा में हुए तो हमारे 3 बच्चे थे, तो उन लोग को फीस को लेकर के जब घर में थोड़ा सा तनाव चलने लगा तो हम बोले कि नहीं, हमको भी कुछ करना है, हम पढ़ लिख के क्या करेंगे, बैठ के अपने बच्चों के लिए कुछ हमको आगे बढ़ना है। तो हम आशा में हुए सर, ऐसे हमको पता चला कि CSC में कुछ निकला है, तो हम आशा में आए यहाँ पे और हुए, अपने बच्चों को पढ़ाए लिखाए। आज वही बच्चे हमारे मतलब एक एनम हो गई और एक बच्चा IIT बॉम्बे में चला गया, एक D फार्मा कर लिया, और इसी आशा से हम लगे रहे। सब हमारे घर वाले हमको अलग भी कर दिए कि अगर आशा की ड्यूटी नहीं छोड़ेंगी तो आप अलग रहिए, लेकिन हम अपने बच्चों के लिए आगे बढ़ने के लिए संघर्ष करते रहें, और जैसे भी बन पाए आज तक वही बच्चे मतलब कामयाबी हासिल कर लिए, और हम अपनी आशा में लगे हैं। हमारे गांव में मतलब एक दूसरे से देख करके कि आशा मैडम का बच्चियाँ है करौली एनम का कोर्स गोरखनाथ में, तो एनम हो गए, सरकारी हो गई, तो हम लोग भी कराए हो। बहुत बच्चे इस समय हमारे गांव में आगे निकल गए हैं। 4-6 बच्चियाँ एनम हो चुकी हैं हमारे ग्राम सभा लौटपुरवा में।
So yes, and another just a wonderful story coming out of this, and so important to have that solidarity and support coming from one of their own when we share these kind of stories. What we see here on this slide is just some efforts that we have taken either through photography or digital art, which again we've worked with healthcare workers to develop some of these things. Just to bring out and sort of almost humanize some of these issues that we only see as data sometimes, or we just pass it off I mean, low resource setting is what we say, and we polish it a little bit. But here, and I was just so moved by this submission on the left. It was an entry to a competition an art competition that we held earlier last month. I think to mark the World Health Worker Week. And the title we had given is A Portrait of Resilience, and the entry came in from Uganda, sharing with the healthcare worker midwife, actually sharing her effort to care for an infant in a setting where there was not enough light, and there's a mother holding a really small old mobile torch, and just the kind of the lengths they go to do what they're dedicated to do, and to just care for those in their community. So just a beautiful piece of photography that sort of caught so many challenges that we try and explain in words. On the right here, we have a collage that we put together using some of the data we picked up from the toolkit that we discussed earlier on the stressors and the coping mechanisms. This one reflected some of the social struggles and so the social factors that are also burdens, but also social factors that help alleviate the stress that health workers are going through and struggling with. So this was also a submission to the Women Deliver conference, and was selected to be displayed at an art hub, which was, I'm not sure the art hub itself, but the conference was attended by over 6,000 participants from 100 odd nations, but just the opportunity to share this story and this reality with so many people has been just an amazing experience of taking these stories and presenting it to the world and to a wider audience. So just quickly summarizing our outcomes and what we see as wins coming out of this is just to be able to give this platform, this space, this increased visibility for healthcare workers to speak of their struggles, but also just to share their stories of strength and resilience and how they've been, just rising above all the odds to continue what it is that they do. And also, I'm sure, calling for action for those areas that just really need support and strengthening from community, from systems as well. So yes, thank you so much for this time and this opportunity, and we just look forward to expanding this work. And we ask for anybody here also to come and bring in ideas, bring in opportunities to be a part of this, and we would love to collaborate, to just sort of see how we can partner in making these stories truly heard. Thank you. I'll just hand over at this point to Ashish and Shilpa for a time of discussion.
Thank you, Nikita. It's I think such a privilege to, as we are listening to each other, to be part of such an effort, and for the contributions. All of us either have been engaged or finding ways of supporting or even serving in difficult contexts. So I think it bears repeating that it's a privilege to be involved in something like this. So we want to just hear or have some interaction, and basically the question we were going to ask of each other is, having experienced these last few years, condensed in the last about a year or about an hour's worth of presentation slides. Let's focus on maybe one thing. What is one part of the work that you just heard about that resonated with you the most? And we're happy for you to come off your mute switch and then come on share, or even put it on chat. What is one specific aspect of the work that resonated with you most? And also, as we move forward, what can we do to keep moving forward? Any ideas or suggestions you have? So 2 things for us to think of and hear each other out. Please feel free to chime in. Patri's saying voices from the front lines, the stories. That's true. I think most of the things that we've heard when I've been sitting with these ladies and being really holding the camera when Sushri or Prachi have been asking questions, it's almost heartbreaking. It can sometimes lead you to tears, knowing how effectively they're doing their work while managing the family responsibilities, while caring not just for the healthcare needs, but also the 15 million things that need to happen in the village: water, sanitation, conflict, other people's children, and so on, but also being able to manage their composure and resilience. So those stories, I think, are really vital for us. So I want to thank Johnson & Johnson Foundation for being with us and supporting us in these journeys, looking at stories. And I think we've taken that risky step of getting involved in leadership as well. But yeah, what else?
I would go with the two kids. That one is really interesting because that one is implemented in also in part of I think the project was created for the India. I'm not so sure about that, but it can even implemented in other areas and contexts like Maldives and then also in Uganda as well. That one make me like how that toolkit is fluid and contextualized, it's fluid to customize in other contexts, in other areas of the world. That one is really fascinating for me. Thank you.
Thank you, Sam. Thank you. And thank you for your contribution as well. You've been selfless in the way that you've continued to work and contribute. We're happy to, take that toolkit in different contexts and have people apply and contextualize it. We've got interest for capturing some of that in the Polynesia and Melanesia, the island areas as well. And so we just got to find a way of taking that and adopting it there. I think I missed a comment and I can't see now. Could anybody read that out, please?
I think we have Henry's hand up.
Please go for it. Please
Go
don't have
ahead,
to raise your hand.
Good afternoon, everyone.
Good afternoon.
I think on behalf of Vision Outreach Zambia, I think it was very interesting to validate these two in Zambia, especially when you look at the ecological model that we used. When you look at the burnout issues, they start at individual level, at family level, at community level, and at system level. So you realize that addressing this burnout among us frontline health workers, you need a holistic approach. And we look forward to a time when we can roll out and probably even develop the burnout strategy in Zambia. Because one of the other interesting parts, apart from the frontline health workers, is also within our education system. I think because Zambia has just introduced the free education, you look at the increase in the number of pupils or learners that have been enrolled in schools. So you might be thinking we are addressing only the health workers, but the education sector also needs to have attention. I think some of these issues, it came at the right time, and I think we really need to see how best we can scale it out at the national level and also come up with a strategy that can address the burnout in this country, focusing in different line ministries so that at the end of the day, we don't put pressure on the health, on the frontline workers, either in means of education, health, even local government, because of even the increase in the population that we have in this country. I think for us as Zambia, we are very excited, and that's why we have been doing even some proposal development so that we can consolidate this idea and also have it, because the Ministry of Health is like taking it as an issue on how best, when you talk about universal health coverage by 2030, one of the key in attaining the universal health coverage is the health worker. How can you motivate the health worker? How can you help the health worker to address certain stresses that affect them so that that universal health coverage that we want to see can be attained? Otherwise, we are grateful to the George Institute. I think this has also given us a way of thinking outside the box on addressing some of the health issues in our country. I thought I would just bring this out.
Thank you. Thank you. And I think we want to tip our hat, really acknowledge your entrepreneurial way of approaching this, right? Because you've not stopped at the toolkit itself. You've gone and layered it across the education system, looking at ministries and so on, which is what we have also been inspired to now experience. Look at how the experience of gig workers or students might be a good place for us to be present, along with others, to be able to look at preventing aspects which generate distress and burnout. So we're happy to continue dialoguing with all of you who are on the call and perhaps who are going to listen into this call as well. But that is perhaps one thread, Sarah, that we are thinking of moving forward with, also expanding that focus beyond frontline healthcare workers to just frontliners as well, but looking backwards or upstream as students and finding ways of contributing. And as Nikita has spoken of, looking at ways in which we sort of enter instead of, the obvious gateways, looking at windows to enter, which is, the art, the humor, the satire, that I think helps communicate the stories much more clearly and deeply. So, but yeah, any other thoughts? Maybe one more person can share, and then I can hand over to Shilpa. Any other thoughts? Anything that stayed with you, resonated with you?
Well, I think I can go. There were some anecdotal experiences that we had when we were, conducting the FLW advisory panel. It was really, heartening to kind of see the FLWs becoming advocates beyond just being the solution users. There was a moment when a panelist proactively reached out unprompted, asking for a Vermi access for a friend who was really struggling. That I think meant more than just themselves, and having used the power of really stepping in, reflecting, and taking care of oneself. And then, you can't pour from an empty cup. So I think the fact that they were able to reflect, see what they can do, and then go beyond was, like, I think aspects like these and instances like these were really, you know, very heartwarming, and felt like this was actually the space that mattered more to them. And there were frontline workers who were, who left the front lines, and then they continued to be part of the panel because I think this effort really mattered more than, just being part of a FLW community. So I think these really stayed on.
Thank you. Thank you, Divya. I know we are running behind time, but I think a few minutes probably are going to be. Sarah, did you want to say anything? I missed something on your chat.
Oh, no, I think somebody else has got their hand up, so I don't want to interrupt. I placed something in the chat there, but Araya, it looks like you've got your hand up.
All right, please go ahead.
Yeah, thank you very much. And I'm so happy to learn from all the experiences. I am from Mekelle. I work for Mekelle University in Tigray, northern part of Ethiopia. And Tigray had been a very devastating war from 2020 to 2022. So all the issues raised here about resilience of healthcare workers really quite resonate to the situation that I'm living and I'm working with, because almost 89% of the health facilities in the region were partially or completely destroyed, and health workers have been facing a lot of challenges during the wartime, in a post-war time, in the post-conflict. Even the healthcare workers have worked for 17 months without receiving any salary. So you can imagine the issue of resilience, the issue of mental health is really very important, and not only in a specific area, but across the globe, because this time the destruction of health systems, criminalization of healthcare workers for service provision in conflict settings is becoming common across the globe. And what I want to resonate here with what has been presented as helping health.
I think we are unable to hear him.
But I think we should, reach back to Araya and just reconnect. Sorry, Araya, I think we lost your audio. I can see you.
Medical doctors are able to take care of their well-being, and they have good or better capacity, resilient capacities. But their resilience capacity is almost similar to the ordinary citizens. So we shouldn't take it for granted that because medical doctors, healthcare workers are treating others or giving care to others, they don't need much assistance. That's what the learning. And one important point that I would like to relate is with the issue of stigma. In particular, in a health system like in Ethiopia, in many African countries, community health systems are politicized. And when there is conflict or armed conflict, the community health workers could be targeted or could be perceived as allies of certain groups or the political systems. So although community health workers are they play a critical role in providing basic services in difficult times, but the community may perceive them as allies or supporters or tools of the enemy or the government and others. So there is a double stigmatization of community health workers in a time of conflict. So how can we understand what are the perceptions of communities toward this community health workers? How can community health workers, frontline health workers, can really protect themselves while providing services is a critical role? And with the digital communication in a time of conflict, in time of war, beyond our expectations, digital communications are lifelines. That is what we have learned in the Tigray context, for instance. There was a complete siege. Internet was shut down. So when communication systems are blocked or when healthcare workers are denied from internet, from any means of communication, this aggravates to lower capacity of resilience. They cannot support each other. They cannot communicate to each other. So we can take this as a weakest point for resilience, and how we as researchers or as implementers or as health system leaders, how can we support frontline health workers to have access for communication with their families, with their peers, health workers, so that they can support each other, they can build their resilient capacity. And that is really important with what you have presented on the WhatsApp approach, how health workers can create a group among themselves, support each other. And with this, I would really very happy to collaborate with the resilient collaborators with the institutes in this initiative. Thank you very much.
Certainly, Mr. Before you leave the conversation, maybe we can just make sure we can set up a time to speak with you and ensure there are a few of us on the call who have had similar experiences in conflict-affected settings, and maybe there could be ways in which we could learn from them and maybe just connect you as well in areas but certainly please just do wait, because we might have a picture and to make sure that we are connected with you. But thank you everyone for sharing your points of view and just being there. I think it just boosts our confidence as well, but also it boosts up the fact that we're working for and with healthcare workers who are perhaps at the front lines of every distress. But again, it's a privilege to be involved in something like this. Shilpa, over to you.
I don't think so I have the time, Ashish, but we can always take this conversation forward. But I want to, just curious as to, Sarah, you had put some messages on the chat, but we haven't heard you today and we miss you. So would you like to share anything?
It's not about me, so that's why I don't want to take away from this. Yes, we were there from the start, but this community has evolved significantly since then, as was the intention. So just a huge thank you to everybody for their passion, tenacity, for really taking the community where it needed to go. I think I put in the chat there just the beyond resilience. This is really now about empowerment, which I think is what is on your next slide through the HEART program, but really moving towards that empowerment, ownership. And I absolutely adore the expression through art. I think that is so powerful as another avenue by which to raise the voices of healthcare workers. So it's not about me, it's about all the other healthcare workers in the community that are on this call, but delighted that you've been able to turn this into something that is so much more above and beyond what it was from the start.
Thank you, Sarah. So, Nikita, we will just, can you go to the next slide? This is the HEART program, and then I can talk about it. Maybe we can connect separately and then discuss in detail. But we are happy that the George Institute has taken has taken the ownership of the HEART program and are currently funding it internally for the next few months. And then we are actively looking to apply for other grants as well to sustain this work. The next slide, Nikita. The next one again. These are some of the proposals we've been actively pursuing, and we're happy that Sushri is able to start her work on the RSTMH grant, and the student healthcare worker mental health and resilience has been shortlisted by CMR, and we hope to go on to the next level. The other one was the APHSR one, which is again we submitted the full proposal and we yet to hear from them. So we continue to work on this, and we are happy to collaborate to apply for more grants to sustain this work. So happy to get onto a conversation, and then please do follow us on LinkedIn or on the website and reach out to us. And then we would love to hear and how we can collaborate. With that, I will hand over to Vardu. Vardu, do you want to close the session?
I think, I will need a whole session to thank the people if I start because there are so many of you involved in it. I think as the host, I will just try to keep it short. My first and sincere thanks to Johnson & Johnson to seed this. It was a small seed, but a very carefully, planted seed, and they really nurtured it till a stage where it can be let on its own. And I think thanks to, Sarah for backing us up all the time through this phase, and to be able to, I'm sure it gives you satisfaction to see the way it has grown, and and it will continue to grow. Cynthia, thanks to you, and a big thanks to both Dimagi and Reach, right? So I think without them, this at least 50% of our work would not have happened of what we have been able to achieve. And I think it's a significant role that both Dimagi and Reach have played in being able to pick up that piece of work and be able to execute it for TRs. Thanks to both Dimagi and Reach as well. And we have had a lot of partners join in between. Like good example will be Vision Outreach Zambia. Like there were so many other partners who just joined in for a particular particular piece of work, and they that did absolute justice to it in a very small time of saying what we tried to do with it. And that list is pretty long. And excellent thing about this thing was, it didn't need a lot of our resources to be able to nurture these relationships, and that continued to stay on and sustain itself for being able to continue this work forward. So I think I thank each one of our partners. They are not distal anymore; they are as proximal as they need to be. We really are thankful to have all those partners as well. I would also pick up Access Health International, who have been very, very generous, and who've been able to identify us as the technical partners for their larger health system resilience work. They said, no, you guys are best in HRH resilience. Why don't you also come on board? And things like that. And lots of other organizations, like small, big, all together, and be able to contribute in completely different ways. Thanks to each one of you. And, thanks is also due to our own team at TGI. I think they also pulled this off in a very, very efficient way for all the confusions that we had in the initial phase of saying, how is that we can shape this work up. But I think we all did all our own small bits and be able to achieve a lot. So thanks to my own team as well. And thanks to everyone. So thanks for all those who have been patiently hearing us through this particular dissemination event. Not many, but I think all those years was completely here, and it was really nice to see all of you here, and here to all our presentations with a lot of patience. Thanks a lot for that as well. Back to you, Shilpa.
Thanks, Vardu. Nikita, do you want to show the next picture? We have like a collage of all the pictures. I might have missed. We didn't have CNI's picture here, so I've not included you. Apologies, CNI, but I think we've included most of it. But it's been like a team effort all through.